Hello? Can you hear me? Okay. Thank you very much. Those of you who know anything about or have been following the behavioral economics literature will know that there's good evidence that judges issue much harsher sentences just before lunchtime. So I urge you to please take it easy on me. I should complain to Ghassan about assigning me last, but anyway, it'll all be over soon and we'll get some lunch. So Anna asked me to come and talk about natural experiments, so I'll talk a little bit about that, although at the very beginning, Anna said, actually, there's nothing more beautiful, I think, than a wonderful descriptive study, and as someone who spends most of his time doing descriptive studies, I heartily agree with that. That being said, I would say for thinking about policy, in many cases what we're really worried about and are interested in are causal effects, and in fact, in the first set of presentations, which were fantastic, I heard several mentions of the idea that if we could make these poor neighborhoods like these rich neighborhoods, we would prevent X number of deaths. If we could, desegregate these neighborhoods and make them different in some way, or if we intervene on this, we would prevent this many deaths. Those are causal claims, and it's important to recognize that those are different than association claims, and we'll talk briefly about that. So what do I mean when I say causal effect? What I mean is, do individuals who are randomly assigned, who we, as investigators, we say, this group gets a pill, this group gets a different kind of pill, and we compare their outcomes, that's a causal effect. And that's to be distinguished from association-based studies where we just find people who are pill takers of type A or type B, or people who use drugs or don't use drugs, and we compare their outcomes. These are people who happen to be treated versus untreated. Do they have different outcomes? And we call the difference between these confounding, actually. So the difference between the effect that we would observe if we intervened to set someone's exposure level to a given level versus what we might see if we just find people out in the community who are treated versus untreated. That's what we call confounding, and it's something that all epidemiologists should be obsessed with, are obsessed with. Okay, so randomized trials versus observational studies. I don't really probably have to go through this, but in randomized trials, right, the treatment or exposure is randomly allocated, and we as investigators have some control over that. So we randomize the treatment assignment. We create exposed and unexposed groups, and we see how they do in terms of their health. In most observational studies, these exposed and unexposed groups just exist in the population, and we follow them up and we look at how their outcomes are. Okay, so I said we're mainly interested in causal effects, so randomization is great. It's a fantastic tool. It's wonderful because when we randomly assign exposures, we know, assuming the randomization works well, that the only differences between the groups that are exposed and unexposed is the treatment itself. And so any differences between those groups and their outcomes we attribute to the treatment. So that's fantastic. But as we all know, randomized controlled trials have very serious limitations. They're often done on very narrow populations. And for many of the questions that we're actually interested in, social exposures, for example, we're not going to be able to do randomized trials. So either because it's unethical, it's impossible to do for things like ethnic background, racial differences in health, for example, or it's extraordinarily expensive to do a randomized study. Again, we have other issues for social exposures in terms of thinking about long latency periods and the complex effects of these interventions. But the bottom line is we need some kind of alternatives to randomized studies if we're going to make some progress on understanding the effects of social exposures and policies. So randomized trials are great because they have high degree of credibility. Because we know about randomized assignment, we can be confident that any differences we see in outcomes are attributable to the treatment itself. When we move into the world of observational data, now we start to talk about all the assumptions we need to maintain in order to interpret differences between exposed and unexposed groups as a causal effect, and that's what we're trying to do. This is a really nice short book by Charles Mansky, and he says in here, again, that the strength of the conclusions drawn in a study should be commensurate with the quality of the evidence when researchers overreach, they not only give away their own credibility, they diminish public trust in science more generally. So what we're really worried about really are the kinds of assumptions we have to maintain in order to interpret an associational study as a causal effect. So for us, what I do, what a lot of people who are doing research in here are doing, is we're often comparing socially advantaged and socially disadvantaged groups in terms of their health. And the main problem that we worry about is people end up being exposed to low levels of education versus high levels of education or poverty in ways that are hard to measure and that might be correlated with their outcomes. So again, we're worried about unmeasured factors that could be confounding these associations. So what do? We adjust. I'm sure you've all said this or heard it or read it, that after we adjusted for long laundry list of things, we found an effect of education on health or whatever, what have you. So we measure and we adjust using regression or other techniques for a whole bunch of confounding factors, and then we say, conditional on all of these things that we've measured and adjusted for, now we're actually supposed to believe that assignment is as good as random. And that's really what we're asking you to believe if we ask you to sort of trust our adjustment. So the issue now is, for observational studies, how credible is this, this assertion? And I'll just give you an example from a paper that was looking at neighborhoods in Philadelphia. Mainly I chose this just because it had an awesome title, which was, "Can You Party Your Way to Health?" It was looking at the kinds of neighborhoods that have block parties versus the kinds of neighborhoods that don't have block parties, I think as a measure of social solidarity. And this is just the basic sort of descriptive table of the two sets of communities. This is the treated group, the untreated group. And what you can see, those of you that care about p-values, you can see all these p-values say that there are a whole bunch of observed differences between these communities. The block party groups are poorer, they're more segregated, they're denser, etc. So the main assumption we have to maintain is that we think that there are no other unmeasured factors that are different between these communities and that could be associated with their health differences. And given these massive differences on all these things that we've measured, I think this is a hard assumption to convince really skeptical people of. And so this leads to hard questions about whether or not we really can attribute any differences between these groups to the effect of block parties. I hope we can, but I like block parties. So another quick example of this, on the individual level, does breastfeeding increase child IQ? There are lots of studies that demonstrate this. A lot of observational studies show higher IQs for breastfed children. So Emily Oster, who many of you may know, she writes for 538.com. She had a long blog post about this that I think illustrates a lot of these issues in terms of thinking about credibility. Again, she says, these studies, the authors say, again, they adjust for differences they see across women, but they still find effects of breastfeeding on child IQ. But this assumes that the adjustments they do are able to remove all of the differences across women. This is extremely unlikely to be the case, and I tend to probably agree with her. I think more damning and more frustrating for us is, in the case of an exposure like breastfeeding, this issue is impossible to ignore, and therefore any study that simply compares breastfed to formula-fed infants is deeply flawed. I mean, she will not be convinced by any observational study that you're going to be able to find the effect of breastfeeding on IQ. It doesn't mean, again, that the results are wrong, but she says it just means that we can't learn much from them. So anyway, I think that's, again, this has to do, though, with the credibility of the assumptions we're willing to make when we're doing these observational studies. So how can natural experiments maybe help us? So natural experiments mimic randomized controlled trials. It's an odd phrasing because usually they're not natural and they're definitely not experiments. They're observational studies, but they mimic randomized controlled trials, and these are usually sort of accidents of chance that basically create treated and control groups that are comparable, and where we think that the treatment assignment is random or as good as random, but we don't have control over the treatment assignment. These things are becoming more popular. This is just looking at Scopus, and again, We're not doing as well as sort of other social sciences in terms of natural or quasi-experiments, but things are on the rise. And just to be a little bit clearer about the language, you'll also see this term quasi-experiment, and I think the key difference I would make, but other people might disagree, is that, again, for natural experiments, we really believe that the treatment assignment based on this accident of chance really is as good as random, and we can still do some very simple analysis to compare the treated and control groups. We don't need a lot of additional fancy modeling assumptions and things like that. So, okay, where do we find these natural experiments? So things like policy changes, eligibility for different kinds of social programs. So programs can be rolled out in a way that lend themselves to analysis by a natural experiment. Lotteries, people in epidemiology like to use genes as randomized instruments. Weather shocks, arbitrary policy or clinical guidelines. We know there are lots of these arbitrary guidelines. Things like plant closures, historical accidents of chance, changes to the physical environment. A lot of these things have been used in a lot of studies to do this, issues of seasonality. So there are a lot of potential sources, and I say potential sources because something happens, there's a weather shock or an arbitrary guideline does not necessarily mean it's going to be a great natural experiment. So what are they good for? I think for us to understand we can use them for a couple of different things. One is to estimate the effect of exposures that are consequences of policies on health. So when we pass a policy like raising tobacco taxes, for example, or anti-smoking legislation, or we change some other aspect of the policy environment, this can lead to different kinds of exposures. So it can help us to learn more about, for example, whether or not education is causally related to health, or how access to healthcare might actually affect health, et cetera, or effects on health behaviors. Also, we can also just look at what the impact of policy is itself on health, again, using policy changes around environment, food policy, employment policy, et cetera. There's a lot of opportunities here for natural experiments to understand the impact of policy on health. So here's a classic example from epidemiology. Anyone who's taught or, taken an introductory epidemiology class has probably learned about John Snow, who taught us a lot about dirty water and cholera. So this is his map of London, and we often teach about John Snow as a public health hero because of the consequences for this intervention. We removed the Broad Street pump and we, impacted cholera. But what I really think we should be teaching about is John Snow as a brilliant person who thought about study design. And he really thought very carefully about how this kind of setup, and this is the case where we had the Lambeth Corporation moving its intake valve to higher up the Thames River for less polluted water, how that might impact cholera deaths. And Snow's work is very compelling because actually he had very good qualitative evidence of the fact that these groups were equivalent before the intervention. Each company supplies rich and poor, large houses and small. There's no differences in the treated and control groups before the intervention. And also that the groups had no knowledge of this happening. So this sample was divided into two groups without their choice and without their knowledge. That is very powerful for us in terms of thinking about trying to mitigate self-selection into exposure. I'll give you one other quick example from a doctoral student at McGill. This question of whether or not getting the human papillomavirus vaccine was controversial in Canada because some people argued that it could lead to risky sexual behavior. This is a hard thing to study observationally because we might think that the kinds of young women who get the vaccine and the kind that don't may be very different in ways that are going to be very hard for us to measure. So the province of Ontario passed a policy to implement this program, and we had a student who used this essentially to predict receipt of the vaccine, but we assume not associated with other things. So we're using the vaccine program as an indicator, an instrument for whether or not people got the vaccine and to look at risky sex. All right, 1 minute, that's going to kill me. Okay. All right, I just want to say this is what a natural experiment looks like. Here's the cutoff date, and this is the quarter of age. And you can see that, in fact, There's very little difference between girls who were eligible versus ineligible for the vaccine. And I think most crucially, I just wanted to show you, in contrast to the observational table, this is the natural experiment table 1, and you can see, in fact, that there are essentially no differences whatsoever on any sociodemographic or health service utilization variables between girls who did and did not get the vaccine. And this helps to make this a much more credible case that we're isolating the actual effect of vaccine receipt on outcomes. Okay, so these are great. Are they always more credible? Of course not. There could really be really bad natural experiments. The key really is this as-if randomization. If this is really credible, it's a much stronger design for generating causal inferences because it helps to eliminate self-selection. And it also allows for, I think, simple and transparent analysis of the results. Again, just because we find a policy, there are all kinds of other assumptions we might need to make, and we have to work hard to make a compelling case that we're close to as-if random when we compare treated and untreated groups. And in many cases, policy changes are often not random. Here we can see alcohol-related mortality going up and potentially an intervention on prices of alcohol. So this raises concerns as well. Finally, again, some drawbacks. We need a lot of qualitative work to make sure these policies are interesting and credible. Thinking about how relevant the intervention is, the relevant of the population that's being affected. And I'll just stop by saying, how do we capitalize? We should take this as-if random very seriously in all of our work. Find natural experiments. We need to teach natural experiments. It's not traditional epidemiology. And I think most importantly, create them in dialogue with people who are making policy. I want to analyze natural experiments. I'd like to work with you if you want to roll out a policy or program. Let's do it in a way that allows for evaluation. Thank you very much.